This is Call the Psychiatrist, the show where psychiatrists answer your questions. I'm Dr. David Handley.
And I'm Dr. Abby Snavely.
On this episode, a listener gets nervous around her therapist and wonders if it's even worth it. Someone wonders why her therapist isn't talking about the diagnosis on her invoice, and a listener wonders what makes a good therapy relationship. And we've got feedback from episode 28, Go Team Sarah.
Say you like me, you better count the ways.
Listening to this podcast does not mean we have a doctor-patient relationship. Our intention is to educate and entertain you. Nothing we say is intended or recommended as a substitute for medical advice, diagnosis, or treatment. Always seek the advice of your own physician or other qualified healthcare professional regarding any medical questions or conditions. This question comes from Bethany.
I am 44 years old and in therapy for anxiety. My job is working as the front desk receptionist at a busy medical office, and sometimes I get overwhelmed and get snippy with our patients. One of the doctors mentioned that I am more irritable lately and suggested I seek therapy. When I realized that I'm smoking half a pack of cigarettes a day, and it's not helping, I thought therapy might be worth a try. The problem is, talking with my therapist makes me so nervous. She is nice and seems kind, but I can barely look her in the eyes when I talk. In fact, when I am talking, sometimes she looks like a giraffe moving her head to try to get me to recognize she is there. I wish I could say, I see you. I just can't look at you right now. The problem is that my inability to look at her probably makes me look more crazy than I really am. Yesterday, my therapist suggested I move closer to her, but I am much more comfortable on the faraway edge of her couch. Sometimes even that seems too close. Her request to have me sit closer to her makes my hands sweat even more. What does this all mean about me? Even though at times I can be snippy, I am not afraid of people. I interact with them all day long. How do I get more comfortable with my therapist? Is it even worth trying?
I mean, I think we have to start with the obvious. Why is this therapist making her move closer? That makes no sense.
Right? It doesn't at all. Is it worth trying in general? Yes. With this lady, I'm not sure.
I seem to be making you nervous. Let me get in your personal space.
Right?
I'm like, what?
Yeah. This is, yes, my inclination would be the opposite. But, maybe we can try to think about what this is about for Bethany. I guess that's what she's asking. And then maybe different ways to work with that in the room. I don't know. I don't know what you're thinking.
Yeah, well, I'm thinking that Bethany's blaming herself for some of this. And I'm like, this therapist isn't really following some social cues there. But that's the part that really stood out to me. Because, I pay attention to where people sit. I'm sure you do too.
Of course.
There's people that try to get as close as possible to me, like on the edge of the couch. They're extended past their knees. And there's people like Bethany buried in the cushions as far away as they could be. They'd be in the hallway, I think, if they could. And I think sometimes it's interesting to pay attention to how that changes over time. And what
Absolutely.
that means.
Yeah. And I try to give people options. I definitely have my chair where my stuff is and my little lumbar support because that's the stage of life I'm in. But, when it's a new patient, I come in and say, well, I sit there, but you can sit anywhere. And I think you're right. It says something, and maybe it even says something worth interpreting at some point, like verbalizing that to the patient, but I'm definitely not going to be one to suggest that something is wrong about what they choose, right? I think it's just a communication.
I probably wouldn't even observe it until it had changed. So the same thing with the not making eye contact. Sometimes I might wait and notice that wow, for the last 5 sessions, they haven't looked at me, but now they're starting to look. And if I thought it would be of service to them to acknowledge that, or also it's less shame inducing the way it is now where she's flagging her down. I was thinking the only time I've ever flagged down a patient to, so that they knew that I was there was dealing with a very narcissistic personality disordered person. You have to make a lot of noise because they can talk for hours and hours and have no idea. You're meaningless to them. And so, you got to get in the game.
That's kind of the opposite, right?
Yeah, exactly.
So for Bethany, I think, like I said, I think this is a communication. And both with the eye contact and the positioning, I think she's trying to negotiate the distance, right? I think she is trying to find a place where she can feel comfortable enough, and that closeness in terms of eye contact and physical space, and I would even say emotional closeness, feels it sounds like it feels a little scary right now. And I think rightfully, she wants to be able to talk about her issues. And so getting a little bit of physical distance, whether that's symbolic or not, makes a lot of sense to me.
Yeah. Yeah. She asked, like, what does it mean about her? Well, it may not mean a lot. I mean, it could mean something around, do you have trouble developing trust in others? Then yeah, this process is going to be a lot harder. But maybe it's also just because going to therapy is really hard and opening up to strangers is hard, and talking about yourself to people you just met. And especially when they're acting that way, not giving you the space that you might need to get vulnerable. I guess what I want to tell her is that some of this is not that abnormal, or maybe there is something there. And then talking about what the experience is like, the way she's even phrased this question is going to be, could be really helpful.
I think so. And I don't think we have an indication of how long this treatment has been going on. But yes, it's totally normal to feel nervous. It's totally, I think, normal and appropriate not to trust somebody right away. I know we've talked about this on the show before, but I think this therapist has to earn your trust. And in this case, I mean, I think the therapist kind of isn't acting very trustworthy in terms of not respecting Bethany's boundaries.
Yeah.
And so, it's not even building trust, it's sort of eroding the trust. And that's kind of, I think, where I get a little, I don't know, I know this is an audio medium, but I'm like, ugh, like, what is this giraffe move? Why is she telling her to come closer? It doesn't seem safe, God.
Right. Well, and she's comparing it to like how she is in the world in her professional capacity at work. She's like, I don't have trouble talking to people at work and in the world. It's like, well, yeah, but this is not the same. These are not equivalent at all. The roles are completely reversed as far as who the expert is. I mean, at work, she's the one helping people. She's helping them navigate a system. They're the ones coming seeking something. And so I hate that. I hate hearing how she's comparing it and deciding that she's in fact more broken than I think she is.
Yeah, kind of fundamentally wrong or damaged. I agree. Well, and another possible interpretation, which would be totally appropriate, but if Bethany is having some fears about this snippiness and what it means, maybe she is really trying to avoid showing that irritability in therapy.
Yeah.
And so I think at some point, people tend to act or show in therapy, relate in a way in therapy that they do in the outside world once they get comfortable enough. But again, I think it's also totally normal and appropriate to want to put your best foot forward, right? Or, she doesn't want to seem too crazy. Maybe she doesn't want to seem too irritable. But what she's really coming for is help. And it doesn't seem like this, I don't know what the idea would be, exposure therapy or forced closeness is getting at that.
Yeah, it's fine if it's exposure therapy. You should probably talk about that.
Well, yeah. I don't think it is. I'm just like, that was like my most, that was my most generous interpretation.
Mine too. Yeah. I was like, but even there, you got to at least say, like, I want you to get closer because it might be helpful. Like we need to still talk about your anxiety around it. Yeah. I hear what you're saying though. Bethany, you need to get a little snippy with this lady, when she's wagging her head at you, call her out. Be like, this isn't helpful.
Yeah,
stop
show
doing
the
that.
snippy. Well, and I guess not to overly identify, but when I was in college, I was a front desk receptionist at a family practice office, and I probably was very snippy sometimes. I'm not saying I did a great job. It sounds like Bethany is a more professional person, but people can be rude, right? I mean, that is a high stress. People call, they are distressed. They're asking for something, probably demanding appointments that may not be available, trying to get to the doctor, right? People are calling and asking for something that she may or may not be able to give them. So, it sounds like the doctor thinks she's overly irritable. It sounds like there's something to address. But it also sounds like, she may just be in a place of trying to understand what is appropriate reactions to people coming at her, whether it's the patients or this therapist. And that could be worthwhile to explore if you can.
Yeah. I don't really like the fact that an employer telling somebody they need to go to therapy.
Yeah.
The fact that it could be that there's a lot of reasons that she's overwhelmed in that job. It might be a bad job. There might be too many expectations. You're right. People may be rude because the doctor is the one running behind. It's interesting that they're making her the identified problem. And I don't think your employer, it's fine for the employer to identify the problem, what's going on at work that might be making the problem, but to then and be supportive. And maybe that was delivered in a supportive way. Are there things outside of work that are getting in the way? And I hope you're getting support for that. But to just say, this is all you and you need to go figure this out without.
Right. Maybe there's things about the job that could be changed that would make it more manageable and less overwhelming.
Yeah. Yeah. So anyway, there were some red flags there. I'm like, I don't know. Might be a crappy job too. Like, it may not just be all your problem.
And maybe the theme in this is people sort of telling Bethany what she needs, and that may not always be the case. I appreciate, obviously, I'm pro therapy. I appreciate that she's being open to therapy. But ideally, the therapy will help you figure out which parts belong to you and are your responsibility and which parts belong to the rest of the world.
Yeah. And if it's anxiety, you're making strides to address that. And in that process, you may realize that I'm anxious and jobs like this aren't for me.
Correct.
And I'm not saying it may not be a crappy job. I'm just saying that there may be circumstances at that job that would make it hard for anybody, whether you have anxiety or not.
Customer service is rough, man.
It's
right?
rough,
yeah. Well, and we may have talked about this before too, but I think an example in my practice is some people who would show up all the time and work hard, maybe not look at me, maybe not whatever, maybe feel really anxious. Once we moved to Zoom, or were forced to because of COVID, it actually was easier for them to open up. And I'm not saying that that is the way for it to be forever, but I think for some people, kind of the safety of the distance of the screen made it feel safe so that at least content-wise, we could go deeper and build trust in a different way. And then when it came time to come back in the office, then I actually think that the Zoom was a useful tool for that trust building. Maybe I was able to understand better the reasons they were nervous or didn't want to make eye contact or were scared. And, we could go from there. Not to say that it wouldn't have happened anyway. I think it can happen all in the office, but I think in that way it was kind of an interesting tool that accelerated some things.
Yeah, that is interesting. Do you think you'd ever make a recommendation for somebody? Like, I've definitely had patients who present the way Bethany's presenting. I don't think I've ever thought about that as a tool to use to say, well, why don't we do the next couple of sessions over the Zoom and see what that feels like, and then we'll reassess.
I haven't done that. It's an interesting idea. I mean, I think there are some people who have a really hard time, and that I've definitely asked, are there things I could do to make this more comfortable? Do you have any ideas about how this might be better? Yeah, I'll have to think about that. I mean, in the handful of cases I'm thinking of, I definitely observed this phenomenon. And I have one patient who still has kept things on Zoom, and she has not wanted to come back in the office. And I bring it up periodically, and she says that she prefers it this way. She prefers the distance. She also noticed that it's easier. And maybe we have it as a goal together in the long run to get back together in the office. But I guess that patient will say, do you think I'm doing something wrong? And to the best of my ability, I don't think she's avoiding anything. And I can tell that we're still doing good work and things are moving forward. So I think it's fine that she stays on Zoom, right? Until maybe, I decide it's some kind of resistance or a way of manifesting something in her life. I might suggest it, but I also wouldn't necessarily force somebody to come back for that reason. Like, there's other reasons I need to physically lay eyes on people. But in terms of the distance, I'm all for letting people negotiate it in the way that they need to. And I think that's far better than missing sessions or canceling or something like that.
Yeah. Well, Bethany, I do think it's worth it. I mean, it sounds like you're working hard, and I hope you keep going. But I do think one way to get more comfortable is going to be actually talking about this experience, how hard it is right now, and see if there can be some accommodations that are made.
Right. And rest assured, I don't think every therapist would approach it this way. At least these two wouldn't. Well, no, I'm just saying, if this is her first experience and she thinks everybody's going to act like a neurotic giraffe and chase me down, that would be really a disincentive to ever try to seek help again.
Well, yeah, because it says that she's not the right candidate for it, right? Like, I can't tolerate it, so I must, this whole therapy thing just isn't for me, which is kind of what she's asking. And it's like, no.
I know.
I think that's a shame. So keep at it. And if ultimately the two of you can't talk about it and get to some other agreement or some other situation, then, maybe ask for some referrals.
I like that. Good luck. Let us know how it goes.
All right, we're going to take a quick break to talk about the last episode. And when we get back, we have a question about how does diagnosis inform therapy?
Dancing just you and me.
We got some feedback from our last episode, including our listener, Sarah, which was very interesting. I think what she's dealing with is maybe even more severe than we knew from her question originally. We don't want to go into all of it, but were there some things that were surprising to you?
I mean, one, I picked the example of the family talking about her menstruation as an outrageous example that would be so far outside the bounds. And it turns out they actually do talk about her periods. I mean, like I tried to go as far out as I could, and it turns out it was true. I don't know.
There were a lot of examples, but the one that really stuck out for me was the mother. I get the one that who could become the future mother-in-law tracks the adult children with GPS. Sarah, we got a lot of feedback from listeners. People really supportive of you. Patricia on our website titled her review, "I'm on Team Sarah." She wrote, "Love the show today and the way you thought through the crowdsourcing problem. I'm with Abby. Run away as fast as you can. Thanks for adding some levity and wisdom to my day." We got some feedback also from Dr. Matt Connor on Facebook. He provided lots of examples from his own practice, including a client who cries daily at how her son's wife has taken him away. He writes, "I want everyone to find love, but remember, when you marry someone, you marry their families and all the patterns that come with them. Sounds like the caller isn't interested or able to join her partner's family and vice versa. And it's 100% okay to use that to end lovingly rather than stay with it and build resentment."
There's that empathy you were looking for, Dave.
You got to have that.
I know.
So thanks, Dr. Connor, and thanks to everybody who let us know their thoughts about Sarah's situation. Sarah, I don't know if that's helpful or not, but a lot of people are rooting for you. I hope you get whatever you need, though, regardless of what you decide about your relationship.
Absolutely. And I hope you get your menstrual issues sorted out.
Yeah, we should all be talking about that.
Right? I mean, now since it's out there.
Sorry, Sarah. This question comes from Jenny. "I'm wondering about how diagnosis fits into therapy. What role does it play? How quickly do you make a diagnosis, and do you reassess? I've been in therapy for a while and making what I believe is progress, but have never received what I would consider a formal diagnosis. I've Googled the codes on my invoices, generalized anxiety, which I assume are there for the purpose of billing my insurance company. But why is something seemingly so basic kept a secret? I know, talk to my therapist. But for some reason or another, I thought my therapist should be talking to me. There's so many frustrating things about therapy that would be helped by a simple practitioner manual. I hate being kept in the dark." Yeah, Jenny, I actually think your therapist should talk to you if they've made a diagnosis, especially if it's going to be on an insurance form.
I think that's right. I mean, I don't think it needs to be kept a secret at all. Thinking about this, I don't know that I always go through with my patients in a really structured way, but maybe that's also based on an assumption that we have a mutual understanding, at least of kind of the basic categories in which this falls. I mean, there are times when someone comes in with a diagnosis or they or their family is worried about something really specific, and I might go into it a lot, but I guess, I might be wrong here, and this question is good. It's making me think through it. But, if I've been talking to someone about their anxiety for X amount of time, but we haven't discussed whether it's, generalized anxiety disorder or social anxiety or something else, maybe I wouldn't have gotten into that a lot in terms of jargon unless I thought there was a clinical reason or a need from the patient to. But you're right. I think the insurance company thing makes it a little bit more important, though we have to kind of wonder what the therapist's goal was here too.
Well, okay, I guess it depends, right? It depends on the diagnosis and how severe it is. But there's plenty of people that come to therapy that do not have a diagnosis. But if you do, you actually meet some criteria for that. And yeah, especially if you're going to put it on some form that really you have no privacy or no control over once it's sent to a large corporation, I do think it's important just to talk about that this is why I think it's accurate. Of course, I'm open to modifying it as we get more information, but this is my best, as far as a provisional diagnosis goes, I think this might be a place that we would start. There's sometimes, though, and I think this could apply to Jenny's therapist, have no idea. Yeah. It's actually possible her therapist doesn't even think she has generalized anxiety disorder, but felt the need to put some code so that it would get reimbursed by an insurance company.
That's right.
And you could say, well, that sounds fraudulent, and I think you'd be right. But at the same time, it might be more fraudulent, not for her to get the care that she is
well, yeah, but, insurance companies are evil and highly unethical. So.
Right. But I still think even if you're doing that, I still think that's a conversation to have, because there's a lot of different ways you can code this stuff with diagnostic codes that aren't necessarily labeling somebody. Because I think that's often what therapists will say is well, I don't really believe in labeling, because then that's, stigmatizing, it's limiting. We need to be more open to these other, that's all fine. Yes. But if it's true, if they actually do have a diagnosis, then it's also okay to use it and to talk about it and talk about why you think it might actually fit, and maybe why in some ways it doesn't fit. And again, if you're on the fence, then that's a worthwhile conversation. And I'll even say, like, maybe for the point of the insurance company, we could say this, because I think this probably describes what you're going through. But we're going to keep working on this as more information comes in. If it's important, then we can keep talking about it.
I think that's right. And so maybe one way to put it is, if Jenny is surprised that she has a symptom of anxiety, then she and her therapist need to back way up in terms of which category this falls under. But even, in kind of like you're saying, Dave, the purpose of these diagnoses tends to be, it can be labeling, which sometimes is helpful, right? Like it can be a shorthand between people, between medical people, or sometimes the doctor and the patient or the therapist and the patient about what's going on, kind of a shared understanding. It can be for the insurance company. It doesn't say anything about where it comes from. It's not talking about the roots or the etiology. I think we have to be careful in terms of what this means for the person's treatment. Also, maybe what it means for an insurance company, sometimes life insurance, things like that, there's implications, or what the patient thinks it means. And, those can all be very different things.
Ideally, diagnosis should dictate something about treatment, and it should tell you something about prognosis.
It tells you something, but not that much.
Right. Depending on the condition you're talking about. And I think that's where I talked about this in a prior episode. It's sometimes you have to define what population are we talking about.
Yeah.
If you're coming in because you have some anxiety, doesn't meet criteria for a label, that's
or disorder.
That's not what we're talking about. But knowing that somebody fits a pattern that looks more like schizophrenia versus bipolar, that's really helpful.
That makes
because
a huge difference.
That really does dictate how we're going to approach this problem. And I can give you more information about what I think the future could look like. But of course, that's just population information. So individual results may vary, but that can still give us some clue about something. It can be reassuring. And I'm not a defender of our diagnostic system. I mean, in the antipsychiatry world, this is where I think people put a lot of their ammunition. It's reductionistic. It's flawed. We're doing what we did over 100 years ago, which is just grouping things together that look alike.
By description, right? But I think that when the plan for the DSM-5 was that they were going to regroup everything based on some neurobiologic basis, but it turns out we don't have the science for that. Like that's not how it works. I mean, my hunch is, or my hope maybe, is that someday we will have better descriptive categories, that everything we're calling depression, that people could have barely any overlap and we're calling it the same illness with allegedly the same treatment. And so maybe we get better at defining these subgroups, and then the diagnoses take on more meaning. And then I guess the flip side, that's the psychiatrist part of me. And then the therapist part of me thinks, well, I don't think people coming to therapy need to have a disorder, human suffering. If you want help, then I want to be able to help you, even if we don't know exactly what to call it.
Yeah, right. There's too many limitations to apply it to all seekers of mental health care. I would still say, though, that having something is better than having nothing. It's just that if you're more cautious, or if you at least try to be accurate as you can and go in with good faith, I think that can be useful. But calling everybody that shows up who's sad that they have major depression, or everybody who's anxious has generalized anxiety, that's not helping anybody.
No, not at all.
But
or even people that have what looks like psychosis. And a lot of times, people will decide that they have had a psychotic symptom, and, they might be right. And then they come in and they say, this is schizophrenia. And it's like, whoa, maybe, but it's a lot more than that.
Or even more lazy is they'll say it's schizoaffective. It's like the big garbage can diagnosis where they just put it all in there. It's like, one of those will stick. It's fine.
Right. Something will shake out.
Yeah. I will say though, but I had an anecdote though about underdiagnosis, like the reason why I think this can be important. So a therapist referred to me someone who very clearly had obsessive compulsive disorder for about 15 years. The obsessions were not the most common. I guess that's how it was missed, but it was very well described in literature, clearly OCD. This person had ended relationships, failed to take job opportunities, felt sure she was morally depraved, And to the point where clearly impaired, suicidal, because how could she possibly be a person in this world with these kinds of thoughts? Mm-hmm. Well, letting her know that this is OCD was incredibly helpful to her. It was, first of all, it helped us have a treatment plan right away. She got better in about 3 months. She was able to join up with other people with similar conditions, which was an amazing relief to her that she wasn't actually a monster. She wasn't alone. She went back to that therapist for a few more sessions. And when she brought this up, was told like, well, I just don't really believe in those labels. And then proceeded to do a therapy that is not at all indicated and probably would have made her worse had they continued on that path.
Yeah. Then I would say, OCD is a diagnosis or condition that does have, like you're saying, very specific treatments that can really help. Right. And that differentiating that from other things is helpful.
Yeah. And that the bar for that shouldn't be so high. Right?
No.
Like if you're going to somebody and they feel qualified to make diagnoses, do you see what I mean? Like I guess I get really angry on this person's behalf because there was a lot of needless suffering. Right.
Yeah.
Right.
But then on the other hand, and I'm not in favor of stigma, but on the other hand, I'm sure you've also had folks come in who say, I totally have OCD, but it's just because like they like things to be clean. And so, you kind of have to back up and talk about, what is OCD versus what is this personality trait, and is it reflecting a different type of anxiety, right? We can't take everything right at its word, whether it comes from a patient or, maybe someone who is less trained in making specific diagnoses. We have to know what we're talking about.
Well, that's the other side of the pendulum, which is the overdiagnosis, which I feel like we've talked about, but. And I hear that the establishment is over-pathologizing human behavior, but humans are over-pathologizing themselves.
Correct.
I mean, people are looking for labels to identify with. So my OCD patient actually benefited from being able to identify that I have a problem with my brain that can be treated. But then it's like you've got a whole group of kids who have been diagnosed on TikTok. Like they're seeking some explanation for how they're seeing the world. And I don't know. Neither of these is right. Like underdiagnosing, overdiagnosing, none of this is okay.
Well, and I get, where the therapists are coming from, like you said, that say, I don't want to label. I also have noticed maybe more these days that seeking a label for some people can serve as a way to just close off any curiosity, where they sort of say, well, I have ADHD and you should know what that means and know what it means for me. Right.
When then it becomes the lens that they look at their entire lives through.
Yes. But any questions I ask, it's like, how dare you? I already told you I have ADHD. And I might even agree they have ADHD, but that doesn't explain everything. And it also isn't an excuse for everything. It kind of points to what needs to be treated. I don't think that anyone's human experience can be encapsulated by a psychiatric diagnosis. But if it explains helpfully some parts of their world, there's this old George Valiant paper, right? That's like the beginning of wisdom is never calling a patient borderline. And I think his point was, if we call a patient borderline, then in some circumstances, then that's just dismissing them and labeling them as bad and excusing whatever bad treatment or dismissiveness that the practitioner can have. But then our old attending and colleague had this paper about how helpful it was to sometimes diagnose people with borderline personality disorder in the emergency room, because it gave a label and it gave a container in a way that's not just I'm crazy and I'm bad. And then, maybe that also gives someone some direction for the kind of help and treatment they need. And it could go both ways.
What's so perverse about that is people are more likely to label a person with borderline personality disorder with a more severe disorder so that they don't have to have the conversation about.
Yeah, right. Because it's really hard because it has been stigmatized. But it's like, no, but there's good news. People get better.
Yeah.
If you're accurate, it's better. And treating somebody like they have bipolar when they really have borderline personality disorder is very destructive and bad.
Right. Because then fast forward a few years and they're on 12 different medications, not getting any better. And but people avoid that. Like they avoid those conversations and it's very frustrating.
I don't know that this therapist is keeping a secret, but I think it is complicated.
What Jenny needs is very straightforward and she's right, I think.
Yep. Yes. Yeah. So how quickly do you make a diagnosis, Dave? And do you reassess?
Yeah, I take as much time as I need,
right?
in my current office.
Right.
I mean,
sometimes it's real obvious and sometimes it takes a long time.
Yeah. I've worked at places where you've got to have something coded by the end of the day. And so, but those are just, I talk about those as provisional diagnoses. Like, based on the data I have today, this is how I might describe it. But, as new information comes in, we need to revisit it. And that happens
all the time.
Yeah, it happens all the time. It happens with all medical diagnoses, actually, right? Like
good point.
In terms of pattern recognition, inductive reasoning, all that kind of thing, it's like, well, I think this is probably congestive heart failure, but why don't we do some imaging? Let's take some labs. Let's get more data and I'll refine the diagnosis over time. The same is true here. Like this isn't a one and done by any means. And again, I would, if a person needed to know at the end of session 1, what do you think? Which most people do want to know what I think. I tell them what I think, not like just here's the diagnosis, but like, these are the things I'm hearing. This is what I wonder about. This is what I wonder maybe treatment could look like for you. But obviously we need to revisit this.
Yeah. And that the questions around it, I think, also evolve over time, right? Some about what is the diagnosis, but like you said, what's the treatment? What's the prognosis? What does this look like? Do I need to do this the rest of my life? Right? I mean, kind of on and on. And so in that way, I think understanding the diagnosis on both sides is pretty important, with always the caveat, that the patient is an individual person and we have to see how it goes for them, right? Sometimes statistics are helpful, but sometimes you are the one in the 10,000 and then we have to be ready to respond to that too. Yeah, Jenny, talk to her about it. Look up generalized anxiety disorder, see what you think fits and doesn't fit. And discuss this part about what it's like to feel like you're being kept in the dark about something about yourself. And if that has a bigger meaning for you, then this might be a really fruitful discussion. And if it doesn't, maybe you just get some clarification about the diagnosis and move forward with what you need to talk about.
Well, it could be really interesting too if together they looked at the criteria to say, oh yeah, I used to actually meet that criteria. Like that probably was a good description for me when we started, and it's really interesting to see how far I've come along. Because she says she's gotten better. It's been helpful.
Yeah, I love that. That's really nice. Good.
Yeah. So
okay, how optimistic of you, Dave?
Sometimes.
I was like, yeah. Every once in a while it comes through. Okay, I won't tell anybody.
This question comes from Patricia.
From what I understand, there's no one size fits all and no two therapies are alike. When you both talk about your therapists, the experiences are starkly different. One is warm and caring, the other is an icebox. Abby has expressed how valuable her therapy was, where Dave has been less forthcoming, but it seems less satisfying. I wonder, from your perspective, what makes a good therapy relationship? Is it something that you consistently work toward? Does the relationship ebb and flow? If you can tolerate a cold, boundaried relationship, can that be fulfilling as well?
Yeah, I think one thing I'm hearing from Patricia's question, if I restate a little bit, it's,
sure.
We talk so much about the importance of the relationship, the alliance that you have between the patient and the therapist. Mm-hmm. It's a big indicator of success or having a good completion to a therapy process. So I guess the question is, what if you don't have a great relationship? You don't have a great alliance. Can you still get something out of it? And I think she's right. She's picked up a lot over the course of the show. Yeah. I guess sometimes I've been subtle. Maybe other times I haven't. So yeah,
the things you leave out also say something.
Always do. So I think she's right. Yeah, I didn't have the kind of alliance that I would want to have with my patients. Yeah. So despite that, it was still helpful. I mean, I still learned about myself. I was still able to make some changes in my life. So it was useful. It was powerful. But yeah, I think her use of less satisfying, maybe not as robust of an experience as I could have gotten. I think all of that is true. But it wasn't that it was ineffective, but it sure would have been nice, I think, to have that other element. I think it would have been... it's a counterfactual, right? Like what more could I've uncovered? What more could I've resolved? I don't know. Who knows? When I think about that experience that I had, and I think about this podcast, there is this theme that emerges about how we're always trying to empower people to talk about the relationship, to say when it's not working, to try to try to say what it is that they need. And even if they don't know how to articulate what they need, to at least be open to bringing that up, that something might be missing or they want it to be different. And I think even in today's episode, I mean, there's the question about why aren't you talking about the diagnosis, or why are you making me sit close to you? I guess I want people to know that it's okay. I couldn't do that for myself in my own treatment, even as I was doing it with my patients, even as I was trying to create an environment where that was going on. I mean, you could argue that that would have been a great theme of my own therapy, not being able to ask for what I need. And that's an example of something that didn't really get explored or uncovered.
Because it wasn't safe enough? Or wasn't that she didn't provide kind of a warm enough environment? I mean, what do you think it was that didn't allow you to kind of speak up for yourself?
Well, I think it's just it's my nature. I mean, are you asking?
Dave, why are you the way you are?
I know, right? I'm like, what? Like,
you're like, this is deep.
Yeah, it wasn't her in that regard. What I'm saying is,
but do you think she could have set the stage for you to eventually have grown more comfortable?
Yes,
in theory, I understand that it's these are thought experiments, but continue.
Yeah, if what you're saying is like, it sounds like what you're asking is, in retrospect, what could I have done differently, or what could be different? Yeah, if I could have vocalized, I need more activity from you. I need more empathic validation. I need more connection. I need for you not to stare at me with those dead eyes, right?
Right.
I don't need the blank screen. Like, this is actually really, really difficult. And I need for you to be engaged more in this process with me, because it feels really scary.
Right.
So that's what I could have said. I don't know that she was capable of providing that.
Yeah, I think that's fair.
And that could have been information for me then too, about like, well, maybe I should look somewhere else. Maybe I should see what this is like with other people.
I think a lot of people can relate to that, right? That the idea that you get to speak up, especially to the expert, right, or the provider, and tell them, this is what I like or don't like, or this is how I'd like it to go. Yeah, I think you are not alone. We can tell, right, from the questions we get and otherwise, that's kind of a radical idea for some people. One thing I wanted to talk about here that Patricia brings up is that she's kind of equating, or I guess tying together, a cold and boundaried relationship versus one that I guess is warmer and maybe with less boundaries. And I guess I want to be really clear. I mean, my therapist, who I talk about with so much affection, who helped me so much, was very boundaried, and in a way that sometimes made me really angry. I do think that fundamentally he is a very caring and warm person. Do I think that he could have been a little bit warmer or demonstrated a little more care, and that might have been easier on me at the beginning? Yes. But the boundaries were kind of rock solid, and in a way, again, that I didn't like or totally understand necessarily at the beginning. But this is a person who helped me. And I had at least 2 therapists before that who were warmer, but with less boundaries, in a way that one guy just talked about his life so much that it was definitely not about me, right? I mean, I know about his vacations and his wife's hysterectomy and all this stuff that, it was just like we were hanging out and sharing stories. And then I thought of this earlier when we were talking about the therapist who demanded closeness. And then this other therapist who I looked down a lot, and he would sometimes kind of kick my foot, like we were really close because the office was small. And he would kick my foot, I guess, to get me to look up. And then at one point he came and sat by me on the couch to try to get me to, I guess, feel closer or connect with him in some way. And that was incredibly intrusive. And I don't know that either of those guys helped me at all, And then there was a big, long break where I didn't go to therapy or seek help until I was in a lot of distress. And so I think that boundaries can go with warmth and helpfulness. And I think a lack of boundaries, even if it feels good, especially at the beginning, could be a red flag.
Yeah, I don't equate cold with boundary. I kind of gave her a pass on just that adjective.
Well, I guess I was just talking about my own experience.
Yeah. No, they're necessary. But I guess, I mean, when I was reading the question, you're right. I'm glad you pointed that out. Being cold is not the same as having good boundaries.
Right.
All the relationships need to have really good and strong boundaries to be helpful. But yeah, I hear what you're saying. You had a couple of creepers for sure.
Well, and the guy who talked about his life so much, I mean, I think his affect was warm, but I didn't really feel cared for, right? I mean, like, because it wasn't about me. And that's a different, I guess, kind of warmth that it's like, oh, I feel so good towards you. I'm going to tell you about my life and problems. It's like, well, I mean, I'm glad, but
well, it's a warm friendship. That's not therapy.
It's a warm friendship. Yeah, we're buddies.
Right.
I was in medical school. It was weird.
Let's see. So are other specific questions, or is it something you consistently work toward? I think it's something that you consistently monitor.
Yes.
I mean, I think if it's there, it does ebb and flow, as she asked. And I think we've talked in other episodes, maybe some of the reasons for ruptures, or maybe it's an interpretation that doesn't land. And you can feel very distant, and it can be very scary when you're not in sync with each other. And so, the therapist should be monitoring it for sure. And if there's been some breach of trust, being able to talk about that, even if it's not the kind of therapy that we tend to talk about here, whether it's a dynamic, inside-oriented, whatever label you want to use, I think this is true of almost every kind of therapy.
I'd agree.
Therapist. I think they, even if you're not interpreting it all the time or paying so much attention to it, like bringing it out in the open, I still think therapists are looking for this because they know how important it is.
I think yes, that the therapists know how important it is, and you're right. We might bring it up more often, but I think if the therapist can be a warm enough, right, stable enough presence that the patient can believe that the therapist is there to be helpful or has the potential to be helpful, then or the doctor for that matter, right? Like it maybe it depends some on what you want from them, but you have to believe, I think, that they have your best interests at heart, which is maybe just the barest foundation of a relationship. But yeah, if it's a therapy that's more manualized or short term or really discrete goals, maybe really liking each other or really getting into it isn't what you're there for, or a medication treatment. But I also think that a relationship enough where you feel like you can talk or work towards talking freely, and that the therapist or doctor is going to be responsive to you, I think, to me, that's part of what makes a relationship good. And that is what I'm working towards, right? Like, can we come to a working relationship where I'm getting enough from them to be able to responsibly treat them, and then hopefully they trust me enough that they can actually be helped.
Well, Patricia, I hope that's helpful. Thank you so much for sending in the question. Also, big thanks to Bethany and Jenny for their questions. And thank you all for listening. If you have questions, send an email or leave an audio message at our website, callthepsychiatrist.com. You can also message us on Instagram or Facebook at Call the Psychiatrist. Finally, tell someone about the show. It's the best way for the show to keep growing. Take care.
Bye.